Hyperemesis gravidarum. Hyperemesis gravidarum is severe nausea and vomiting during pregnancy that results in dehydration, weight loss, and ketosis. Diagnosis is clinical and by measurement of urine ketones, serum electrolytes, and renal function. Treatment is with temporary suspension of oral intake and with 4 fluids, antiemetics if needed, and vitamin and electrolyte repletion. Pregnancy frequently causes nausea and vomiting. The cause appears to be rapidly increasing levels of estrogens or the beta subunit of human chorionic gonadotropin, beta-HCG. Vomiting usually develops at about 5 weeks gestation, peaks at about 9 weeks, and disappears by about 16 or 18 weeks. It is often called morning sickness, but it can occur any time of day. Women with normal nausea and vomiting during pregnancy usually continue to gain weight and do not become dehydrated. Hyperemesis gravidarum is an extreme form of normal nausea and vomiting during pregnancy. It can be distinguished because it causes the following: weight loss, greater than 5% of weight, dehydration, ketosis, electrolyte abnormalities in many women. As dehydration progresses, it can cause tachycardia and hypotension. Hyperemesis gravidarum may cause mild, transient hyperthyroidism. Hyperemesis gravidarum that persists past 16 to 18 weeks is uncommon but may seriously damage the liver, causing severe centrolobular necrosis or widespread fatty degeneration, and may cause Wernicke encephalopathy or esophageal rupture. Diagnosis of hyperemesis gravidarum. Sometimes serial weight measurements, urine ketones, serum electrolytes and renal function tests. Clinicians suspect hyperemesis gravidarum based on symptoms, e.g., onset, duration, and frequency of vomiting, exacerbating and relieving factors, type and amount of emesis. Serial weight measurements can support the diagnosis. If hyperemesis gravidarum is suspected, urine ketones, thyroid-stimulating hormone, serum electrolytes, blood urea nitrogen, BUN, creatinine, aspartate aminotransferase, AST, alanine aminotransferase, ALT, magnesium, and phosphorus are measured. Obstetric ultrasonography should be done to rule out hydatidiform mole and check for multifetal pregnancy. Differential diagnosis. Other disorders that can cause vomiting must be excluded. They include gastroenteritis, hepatitis, appendicitis, cholecystitis, other biliary tract disorders, peptic ulcer disease, intestinal obstruction, hyperthyroidism not caused by hyperemesis gravidarum, e.g., caused by Graves' disease, gestational trophoblastic disease, nephrolithiasis, pyelonephritis, diabetic ketoacidosis or gastroparesis, benign intracranial hypertension, and migraine headaches. Prominent symptoms in addition to nausea and vomiting often suggest another cause. Tests for alternative diagnoses are done based on laboratory, clinical, or ultrasound findings. Treatment of hyperemesis gravidarum. Temporary suspension of oral intake, followed by gradual resumption. Fluids, thiamine, multivitamins, and electrolytes as needed. Antiemetics if needed. Rarely, total parenteral nutrition. At first, patients are given nothing by mouth. Initial treatment is 4-fluid resuscitation, beginning with 2 L of Ringer's lactate infused over 3 hours to maintain a urine output of greater than 100 ml per hour. If dextrose is given, thiamine 100 mg should be given first to prevent Wernicke encephalopathy. This dose of thiamine should be given daily for 3 days. Subsequent fluid requirements vary with patient response, but may be as much as 1 L every 4 hours or so for up to 3 days. Electrolyte deficiencies are treated, potassium, magnesium, and phosphorus are replaced as needed. Care must be taken not to correct low plasma sodium levels too quickly because too rapid correction can cause osmotic demyelination syndrome. Vomiting that persists after initial fluid and electrolyte replacement is treated with antiemetics and other medications taken as needed. Vitamin B6 10 to 25 mg orally every 8 hours or every 6 hours. Doxylamine 12.5 mg orally every 8 hours or every 6 hours can be taken in addition to vitamin B6. Promethazine 12.5 to 25 mg orally, IM, or rectally every 4 to 8 hours. metoclopramide 5 to 10 mg 4 or orally every 6 to 8 hours. Ondansetron 8 mg orally or IM every 12 hours, for use before 10 weeks gestation. Potential risks of congenital defects should be considered. Prochlorperazine 5 to 10 mg orally, 4, or IM every 6 hours or 25 mg rectally 2 times a day, as needed. After dehydration and acute vomiting resolve, small amounts of oral fluids are given. Patients who cannot tolerate any oral fluids after 4 rehydration and antiemetics may need to be hospitalized or given IV therapy at home and take nothing by mouth for a longer period, sometimes several days or more. Once patients tolerate fluids, they can eat small, bland meals, and diet is expanded as tolerated. For vitamin therapy is required initially and until vitamins can be taken by mouth. If treatment is ineffective, corticosteroids may be tried, e.g., methylprednisolone 16 mg every 8 hours orally or 4 may be given for 3 days, then tapered over 2 weeks to the lowest effective dose. Corticosteroids should be used for 6 weeks and with extreme caution. They should not be used during fetal organogenesis, between 20 and 56 days after fertilization. Use of these drugs during the first trimester is weakly associated with facial clefting. The mechanism for corticosteroids' effect on nausea is unclear. In extreme cases, total parenteral nutrition, TPN, has been used, although its use is generally discouraged. Rarely, progressive weight loss, jaundice, or persistent tachycardia may occur despite treatment. In such cases, termination of the pregnancy may be offered, if it is available.